For testing and diagnosis, the issues were, again, widespread variation in practice. The majority of people who are infected are undiagnosed. And the aims were to look at trying to look at innovative approaches to primary care testing and referral activities, and to have a sort of national and local campaigns to raise awareness of testing. And again, we're looking at the performance indicators to see how many people are coming forward for testing and diagnosis. And this is perhaps where we can see that the first year of the action plan, which was 2008, we really stood still. 2009, which is the first year where actually things started to be put into place, and actually these systems were starting to work. We start to see that's the first year we get a significant increase, and hopefully 2010 will overhaul that figure again. Because the 3 years of the action plan, we had no money came out before the phase 2 of the action plan. So the first year was almost like a pump priming to get things in place. The second year was to actually fund the new networks and things that were set up. And the third year is to cut out for treatment. And so this year is the year it tells if what we've tried to do in the last 2 or 3 years is going to work. So there's a little bit of pressure. But what we've been able to achieve is that we've increased our antibody testing by 20% in 3 years, increased our diagnostic yield by about 30%. And public awareness campaigns, which probably you'd think are key to actually driven this, were actually delayed considerably by the H1N1 pandemic. And in fact, that delayed it by 6-8 months, which may skew what we're seeing in terms of people presenting for testing. And we're also starting to roll out dry blood spot testing across the piece. For the treatment and care, our issues were that there was variable amount of clinical management and social care practice between some people were engaged with the drug addiction services and the psychiatry services at the treatment centres, other people weren't, and insufficient numbers really were going into therapy. So what we did is we set up managed care networks between all the health boards, which was, as well as having lay members, we were also having representatives of all the different groups. And these services were ramped up over the 2 years to actually look to increase the numbers treated. And also for prisons, we were looking to actually get them on board. We were starting to look at in-reach services to prisons, and we had service level agreements with each of the prisons and the health boards, and memorandum of understanding about who does the testing, who does the treatment, and the numbers will be expected to come out of it. And so we look at the number of people being treated as one of our performance indicators. And so going from, in the 2 years we've been running, we've gone to nearly doubling what we're doing. From 2007 to 2009, we've gone up from 460 to 900, and with a view to be going up to well over 1,200 hopefully next year, although obviously if cost constraint that there may be some cap put on that. But we're exceeding our targets which were set at the moment. And in terms of our in-reach into prisons, we've seen a really big increase. All the health boards have got in-reach services now to each of the prisons. Myself, I go into 3 different prisons, one session a week, and we're treating patients in prisons, and they're actually probably the easiest group to treat, I've got to be honest. How do we do? Well, actually all we can tell you is what it was like at the start, because we haven't really got the data to say what it's like now. We've put into place all this, the networks and all the enhanced services. So before we started, this is looking back at the last 1,000 people treated in Scotland before the action plan kicked off for phase 2. That's up to 2007. You see, it's very similar to the data from Trent in England, where we're looking at in genotype 1s it's 39%. Genotype 2-3s, just under 70%, and overall of just about 60%. So it's comparable to what's happening in England in terms of a region which is collecting data. We've got really quite good data with a national database looking at the treatment side of things. And what we'll be able to do now is see what's going to happen with the enhanced services in the phase 2 of the action plan, and see if we can actually start improving the success rates simply and the SVR rates by providing the more integrated services. The other thing which we've been successful in doing with treatment and care is the drug procurement, in that we've been able to get a 20% reduction in drug costs simply by bidding on block as Scotland to get the drugs out of the companies, and that's been a real benefit in terms of improving our the numbers we put into treatment. We've gone to a lot of workforce development and education networks where we're actually looking to enhance the training and competencies of all the staff, whether or not it be people at the front door with the drug services, right through to the people who are helping to support in the psychiatric services. And so what we've done is doubling up the numbers of people in treatment. The other achievements is we've, rather like the Welsh plan, is that we've got a governance structure which is tightly monitoring the health boards to make sure they're pulling the finger out and doing what we're supposed to be doing with the money. And that's constantly coming around, checking to make sure that we're getting the data in and that we're actually performing as per our targets. We've also got really quite an integrated national networks, both with clinicians, the addiction services, the voluntary agencies, and the public health scientists, all to share information, share best practice, put together what we think works in our area. We can then spread it and allow dissemination of good practice. And the important thing is also that we're actually looking at the data and the information. We're trying to get really hard data on everything we do to justify what we're doing. So what the challenges left, I've just run slightly over, but I'm just going to finish off on the 2-3 slides. We found there's been a variability in the size of the health board. The smaller health boards have struggled, particularly with the distraction of the H1N1 activities, and that put us behind a little bit. And also knowing that we have to recruit for a long time, but with limited money. We've got short-term funding, which theoretically at phase 2 ends in about about 6 months' time. But we've had to recruit people on a permanent basis, and this has caused challenges to various health boards. We've not been able to run out what we'd hoped would be an interesting pilot study in prisons, where we looked at needle exchange due to prison officer unions' concerns about this. And also we were hoping to embed standards and targets put up by what we have in Scotland, the Quality Improvement Scotland QIS standards, which become embedded into what the health boards have to produce. And this would be our sort of get out of jail card, that if we've lost central funding, that the health boards would still have to produce to that standard. And that's been delayed because of changes within the QIS programmes. And in the end, perhaps our biggest risk is the prevention awareness in the high-risk population. Because what we've seen, even though we've been, over the last few years, is really working hard at trying to get harm reduction measures out. This is the last snapshot we did, and it shows that even now, despite starting to ramp up the services, we're getting 48% of people in the last 6 months who we use spoons, filters and waters which have been used by somebody else. So that message still hasn't got through, although a lot more are reusing their own needle, and only 15% are using other people's needles and syringes, but there's still a big issue around paraphernalia. So our biggest challenge is still to come. One, we've got to convince the government that what we're doing is producing the goods, and hopefully we're going to have the information and to actually be able to convince them that this is the case. And then what happens beyond what is phase 3, which is hopefully we're going to run for the next 3 years, is how to embed the structures we've put into place into the day job, basically. And I'd like to thank everyone at the Health Protection Scotland and the people at the stakeholders conference who allowed me to use their slides. But in the end, it's the people down on the shop floor, it's the data managers and the people who are actually working in the clinics who've provided all the information which you see today. So thank them. Thank you very much.